Good afternoon, and thanks very much to everyone who's taking the time to join us today. I'm James Downey, I'm the Independent Hospital Pricing Authority, and it's my pleasure to welcome you to this webinar. First, I'd like to begin by acknowledging the traditional custodians of the lands on which we are meeting around the country today. For me, it's the Gadigal people of the Eora Nation, and I recognise their continuing connection to water, and land and culture. I pay my respect to elders today and those who walk in spirit. So it's great to be back with our first Q&A webinar for 2022. When we launched the series in June last year, we knew obviously it was in a very challenging environment when everyone in the healthcare sector was incredibly busy. Unfortunately, that's still the case. So for taking the time out today, and just also want to pay, thanks to everyone who's working so hard in the health sector at the moment. I know you're all under an enormous amount of strain, be it in hospitals or in various health departments around the country. We really do appreciate your efforts. With each of these sessions in the series, our goal has been to facilitate a discussion that can help you in your role, but also allow you a chance to talk to people who are experts in their field. So today's webinar, we're focusing on the systems and processes that provide a consistent framework to which to report, measure and benchmark hospital costs and activity collections, which is just critically important, both to IHPA's work, but also to the health system as a whole. And I think we've all seen in this period of the pandemic just how important having real-time data is. So IHPA, as many of you know, maintains the annual National Hospital Cost Data collection across a number of activity streams. We also work very closely with the Australian Institute of Health and Welfare and obviously the states and territories around activity data sets as well, and making sure they're consistent across the states and territories. And I will just make the comment that we are incredibly lucky in Australia. Extremely well specified and well-defined data collections, and amazingly for a federal, really good consistency across the states and territories. And when we talk to countries who are thinking about doing ABF or other things, often they're starting from a long way behind where they don't even have consistent activity data sets, let alone cost data. So we really are lucky. So today we've got an excellent group of senior leaders from IHPA, from the Australian Institute of Health and Welfare, and also from the New South Wales Ministry of Health on the panel. And our moderator, Dr. Trent Yeend, will introduce them shortly. If you joined us before in the series, you know how this works, that we jump straight into the discussion and open up to questions that were submitted through our Q&A panel function. And I'm really following the discussion. If you've missed any of the previous sessions in the series, you can find the recordings on the web. And they've covered policy development, safety and quality reforms, classifications and costing. So now, moderator today, who many of you will recognise from previous sessions, and it's Dr. Trent Yeend, who's our senior data scientist here at IHPA. Trent has a PhD in mathematics and over 15 years experience in data analytics, statistical modelling and policy advice in the public sector and in academia. He's been with IHPA since we were established in 2011, so more, and it's actually one of our longest serving members of staff. And his work has included the developing national pricing model, and has worked extensively on the DRG system as well as mental health. So I hope you enjoy today's session, and I look forward to the session which we held in April, and I'll hand over to you. Thanks, Trent.
All right, thanks, James. Good afternoon and welcome to the fifth instalment of the Independent Hospital Pricing Authority live Q&A webinar series. Today's session is titled Every Patient Counts, Adding Value, Efficiency and Transparency Through Accurate Health Data. The session will focus on ways in which accurate health data collection, reporting and analysis is undertaken to inform decisions across the Australian health system. You can find a really useful overview of the range of data-related processes at IHPA that IHPA undertakes in our introductory presentation available on the IHPA's YouTube channel. The purpose of today's session is to provide you, the audience, with the opportunity to engage directly with our panelists who share an extensive knowledge on the collection and use of data across our health system. I have around 50 minutes to take your questions, which I encourage you to post via the Q&A widget in your browser window. You can also upvote other audience questions that are of interest to you. Let me now introduce our four panelists. First, we have Julia Hume, Executive Director, Costing and Data Infrastructure here at the Independent Hospital Pricing Authority. Julia leads the teams responsible for the functions of costing, data acquisition and IT infrastructure at IHPA. Julia has worked extensively on the National Hospital Cost Data Collection, or NHCDC, for both public and private sectors. She holds a Bachelor of Applied Science in Health Information Management and a Master's in Political Economy from the University of Sydney. Julia has previously held roles in health insurance, cancer research, and international post-conflict development in several countries. Our next IHPA panelist is Laura Harris, Director of Classifications. Laura leads the agency's work involving the development and refinement of health classification systems. She holds 2 bachelor degrees from the University of New South Wales in exercise physiology and in science in neuroscience with honours, as well as a Master's in Health Information Management from the University of Tasmania. And prior to joining IHPA, Laura worked in medical research and at New South Wales Health in positions involving strategic and operational health information management. Joining our IHPA panelists, we have Kieron McGlone, Director Information and Quality at the New South Wales Ministry of Health. Kieron has 28 years experience working in the New South Wales Health Information Technology domain. He's been involved in statewide programs of work, including in mental health data and in the fields of drug and alcohol. In his current role in the New South Wales Ministry of Health, Kieron is responsible for supporting the collection of data into the state data warehouse and ensuring the information collected is fit for purpose with respect to local, state and national reporting by implementing and maintaining data standards and data governance. And our fourth panelist is Dr. Adrian Webster, Head of the Health Systems Group at the Australian Institute of Health and Welfare. Adrian's group at the IHW focuses on the activity, performance and financing of the Australian health system. This includes maintaining national hospital data collections, producing an annual record on health spending in Australia, monitoring performance and safety of the health system, and reporting on activity in the medical, dental and pharmaceutical sectors. Adrian is a sociologist with more than 20 years experience studying and working in the health and welfare sectors across Australia and overseas. So welcome to our panelists. We'll jump right in, as James said, while we wait for the live Q&A questions to start coming through. And given the introductory presentation on our YouTube channel focuses on IHPA and its processes, I'd like to start our discussion today by asking Adrian and Kieron if they'd like to each provide an overview of the data collection processes within their own agencies and the coordination of these processes with data providers.
Definitely starting with the easy question. The process of data collection is quite a difficult one. It sounds reasonably easy, but there's a number of processes of ensuring that the information that you're collecting makes sense, that it is actually be collecting by your systems, that the people who are collecting the data understand what it is that you're collecting, and the people who, excuse me, who are interpreting that data understand how it's being used and understand how it's been defined. And that's done through an entire process of working with the Australian Institute of Health and Welfare, working through the National Health Information Steering Data Committee to ensure that we're collecting standards across Australia. We implement those into our systems, work with our vendors, define what is required, ensure that the staff that are collecting the information is aware of what it is that they're collecting, and build an entire process of trying to get it from the clinical collection point through their local system and up to a state system that we could then do state level reporting, provide it back to the districts and networks, and of course provide it nationally. that again sounds quite easy. The problem is, and New South Wales is not a different jurisdiction in this accord to other places. There are multiple systems, there are multiple vendors, there are multiple collectors. We have to work with them on almost a one-by-one basis to ensure that the data does flow in the way that we want it. One of the most important things I think about the data collections that we manage is ensuring that the metadata standards are available. People understand what they're collecting, they understand how they fit together, but also a data quality process. It's in my title. It's very important that we do review the data quality of the information flowing through the system so that when we get to the end point of reporting, it actually reflects what's happening. And I think that's something, and I remember a number of discussions, Adrian and James, around data information, ensuring that what we're collecting actually reflects what's happening on the ground and is understood by the people on the ground, and the endpoint can be brought back to the people who are setting the system up and using the system to understand what is actually happening in that client space. I sound like I've made a political statement.
I just want to acknowledge what James had said in the intro about how very fortunate we are in Australia to have the systems in place and the endeavour that we all partake in to get these collections together. I actually think, I was reflecting on this earlier today in a different context, that in the notion and the context of interjurisdictional data sharing, when you look across our whole federation, I suspect that what we do with the hospital's data collections nationally is unparalleled. There's no greater endeavour that we partake in as a federation in terms of data sharing, I suspect, than what we do with hospitals' data. In terms of our processes, I definitely sit here on the shoulders of giants who have come before me, in the sense that many of the core aspects of what we do and how we do were actually laid down and developed in the late 80s, early 90s, and have been refined over that time. But at their core, they remain very valid and very relevant. And these are things like Meteor, the metadata specification system that we use. Many ways, I like to see Meteor as being a kind of score-keeping record, which has kept score of all the debates that have happened over the years between all the lauded experts in the hospital's data realm about how to measure what a bed is and what a hospital is, and how to measure waiting times and all these sorts of things. I think Meteor is often a process of debate, negotiation, and ultimate kind of consensus outcome that's pretty remarkable as a system and as an endeavour. I use that term a bit because I think that's key to what we do. We developed this process as part of a service, in a sense, certainly from the IHW's perspective, that we provide largely to the states and territories, although there's obviously Commonwealth interest as well. But the key stakeholders are the states and territories who we facilitate a discussion between in many ways. And that's certainly how it began. The notion being, let's get everyone together, work out how we can make it make sense, reflect what actually happens in reality, acknowledging that the reality is very different from hospital to hospital and state to state, and try and come up with a standard process. So we use that, we get agreement, usually a year or so in advance of the collection period coming through. We get that documented in Meteor, working with IHPA and many agencies to make that happen. It flows through, and then it comes through to us via a tool that we developed a few years ago called Validata, which gets us a certain way in terms of just checking the data sets and making sure that they reflect the spec. But then post receipt, there's also a huge amount of validation and QA and interaction that goes back and forth between us and the states and territories. Before then, we will ultimately publish the data sets. Often that's not the end of the story, of course. Once you go and publish it, sometimes people find things that suggest there might be quirks in the work, and we go back and fix that. But at that broad level, that's kind kind of how we work. Very consensus-based, very interactive. Underpinning it all is a legislative framework, which I think is important to acknowledge. Under the terms of our legislation, the data provider has ultimate say at the end of the day about what we can and can't do with the data. So we sit and work within a governance arrangement that is really reflective of the state of play, the interests and the kind of tolerance levels within the states and territories around how they want to see the data get used.
All right, thanks. So the questions have started to come through. So maybe one for Julia, I think. So apparently the time for from data collection to utilisation in ABF is about 2 years. Is that correct? And what might reduce this lag?
Thanks, Trent, and thank you for the question. I think that IHPA generally collects activity data from jurisdictions through hospitals to jurisdictions within 3 months of the separation of the patient's activity. We do use that data to track trends and be able to monitor what's happening in the system nationally. We also share that information with the National Health Funding Body, and they utilise that data for the purposes of funding. We also understand that jurisdictions also use that data in that as they receive. In terms of the ABF data informing a national efficient price, then yes, there is around a 2-year delay in that. However, we're also using it for classification development within that time frame. In terms of the time frames, I think that we often have these discussions with jurisdictions, as W does as well. There needs to be the quality of data, the process for coding that data is also quite time consuming, and that needs to be considered when we're collecting the data. The other data collection that we have, the NHCDC, the cost data collection, IHPA receives that data approximately 6 to 8 after the end of the financial year. That data collection requires the financial year point in time to see a complete collection submitted.
Well, maybe it's just an extension of that same question. So another question's come through that says the IHPA portal has just been updated with the 2019-20 financial year cost results. The cost report, I think that's referring to, this is 12 months after submission. Is there any way this lag can be reduced? So again, it's talking about, I guess, those actual data-related processes, as well as the work that needs to be undertaken to prepare the results.
Yeah, so that's the benchmarking portal has been updated. Once we receive the data ourselves, so if IHPA receives that the 2020 data at the beginning of 2021, we then undertake a financial review, determine how the Australian patient costing standards have been applied to that data. We produce a cost report. So there's a being undertaken. It is a slow process, perhaps, to make it publicly available or available in the benchmark report, which is not publicly available.
So Kieron said at the start, I introduced with one of the easy questions, which I took as a prompt to give him something that more difficult that he could work with. So maybe for the entire panel, so how can we improve the use of existing data collections across the health sector to support the integration of care across primary, hospital and aged care settings?
I really think, Trent, one of the things with the data is a number of our processes are based on a set process that takes time. We do a data quality process. We get the information, we consolidate the information, we put it with other information sources. So some of those aren't really set up at the moment to cope with that more real time. I think a number of us, including myself, have been excited by a lot of the interactive real-time reporting that we can get out of various environments. I don't think it's quite hit this particular area yet, and it would require a negotiation with IHPA and the administrator and AHW and the jurisdictions to see about how that data spigot could be turned on more quickly. But also keeping in mind, you want this data to be quality, you want this data to reflect what's happening, and you want the errors fixed before you release it, because it's very important funding information that we're talking about, or costing information we're talking about here. So I think there are processes, there are ways that jurisdictions, the government can work, the Commonwealth government can work together to speed up some of those processes, but I'd be a little bit wary to make sure that we're not sacrificing quality as we're doing that.
Adrian, what about you? What about integration of these existing data collections across settings to try and provide insights and support integrated care?
Yeah, look, it's been a huge area of focus for us probably over the last 10, 15 years to get better data linkage infrastructure in place specifically to address this issue. Over the last few years, something that's come online called the NISI, which is the National Integrated Health Services Information Analytical Asset, and that just rolls off the tongue so beautifully. The NISI AA, as we call it, brings together MBS, PBS, hospitals, aged care, and mortality data, all linked up for now, I think, a 9-year period. So you're able to follow an individual across all of those systems. It's fair to say, though, that we're only really developing now the analytical tools and abilities and capability across the country to extract intelligence from those sorts of data sources, because we all know the hospital's data in and of itself is complicated enough, but you start putting it together with MBS and PBS and all these other things, and you increase the degree of complexity exponentially. Having said that, over the last few years, we've really pushed forward, and I've particularly kind of been keen to push forward an alternate approach, well, not an alternate, but an additional approach that does yield insights in a far more operational sense. In the COVID context, obviously the demand for real-time data has been paramount. The need to be able to see what's going on, respond, has been there every day of the week. But what hasn't been there and has never been there in the Australian context is to be able to see what's happening in a local area with the hospital system, as well as the MBS system, as well as what's going on in pharmacies, as well as what's happening in immunisation and these things. So we've put a lot of work into a system, it's called Florence, after Florence Nightingale, because we kind of feel like this was her dream all those centuries ago. And it's still very early days, but it's amazing what intelligence you can extract from a system that does just bring together at an aggregate level. This is not unit record data. This is just, you know, total ED presentations alongside GP services in the same LGA. And then, you know, mapped against, well, what happens when a suburb goes into lockdown? Well, we know now, you know, EDs drop straight away. Pharmacies go through the roof first day of a lockdown because everybody, or the day before often, because everybody rushes to the pharmacy. Telehealth starts to, you know, pick up as face-to-face drops down. Well, so much stuff going on, so much stuff is obvious. Things that we've seen that are not so obvious are, well, opioid use starts to decline. Antibiotic use seems to decline during lockdowns. So this has been a big problem. I don't think we've solved it, but I think the future will require a multitude of approaches. Pretty obvious cliche thing to say, I know, but one thing I'm passionate about is, yes, we need the linked work, we need the really kind of detailed stuff, but we've gone nowhere near getting the real value out of what we've got already from the aggregate data in and of itself at a high level to really be able to understand some of the relationships between, you know, the big issue. If you lose a GP in an area, what happens to ED presentations? Obvious things to look at. You don't need linked data to do that. I think there's hope on the horizon if we can really leverage what we've already got in a better way.
All right, thanks. The questions are really coming through now, so we'll try and get through as many as we can. How is IHPA or other health agencies planning to improve the capture of gender diversity within the data collection process? Currently, there is no simple or nationally consistent way for patients who identify outside the gender binary to express their lived identity, and our data is not reflecting how this part of the population is interacting with our health services. Is this an area of data collection we can development on in the future?
Yes. There is actual papers up with the NADIS committee at the moment. They've actually released some information on gender and guidelines around collection. The jurisdictions have been released that information. They've accepted as a way of moving forward. It may take a while to get into our national collections, but the process is already underway at the jurisdictional level to bring that in so that we can report it nationally. So that information is actually available. I think if we have an ability to share information with this group, we'll make sure that they see those papers.
And I might just add to that, if that's okay, Trent, just, talking about our classifications. So in the development of the AR-DRG version 11, sections will be used as a way to accurately group episodes, but I guess the significance of this will be reduced. So that will sort of limit how many episodes actually utilise that administrative sex value to be able to group out episodes.
Thanks. So one on new technology. So is there a pricing, legislative or data framework to keeping up with the rapid innovation and political push towards telehealth or virtual models of care, and more importantly, keeping an early and close eye on the patient outcomes versus transactional process measures related to that form of healthcare delivered versus face-to-face?
Hi. That was, I think, quite a broad question. I can say there are some legislative or NHRA requirements around how we consider new health technology more at the high cost, highly specialised. In the non-admitted patient data collection, we do identify whether or not services are delivered via telehealth, and we are incorporating that information when we're pricing services as well. I think the question was a bit broader.
Trent, I can probably,
as well, if you want.
Yeah, comment a little bit on some of the more broader safety and quality dimensions of it. I mean, not that there's a specific answer necessarily. One of the problems being telehealth and telemedicine, they're actually potentially two different things or subsets of each other. Getting definitions of what actually we're talking about here is I don't think it's been done yet. It's early, but I am expecting that there will be enormous amounts of research over the next couple of years, particularly using the linked data to look at outcomes for people that have accessed, say, a telehealth GP consult during a lockdown, compared to those that haven't, and look at their mortality outcomes, hospitalisation rates. All that is certainly eminently possible now. The framework dimension of that, of course, is you've got to put that in the context of how we manage outcomes in the health system more broadly, and a lot of that is about professional registration, college surgeons and other college standards, and clinical governance. I don't know that you can point to a single framework that relates specifically to telemedicine in that regard.
So move on to the next question. So this is really, how does IHPA or anyone else really plan on addressing, or how are they addressing variations in coding advice across jurisdictions? And of course, cognizant of the extent to which this may be impacting on data collection and potential pricing or revenue, funding across the jurisdictions.
So I might start off on that one. And I guess this is where sort of in the presentation we went through some of that think this is really sort of where things start, and making sure that we develop data standards that are consistent, ensures that the way that we collect this information for our ABF classifications will be consistent across, you know, different hospitals nationally in Australia.
Okay. No one else, then I might just jump on to the next question. So when might the non-admitted patient activity collection get some attention, particularly a better classification system?
That one again. I guess every year it's currently happening now that we do have a look at all of our data systems in terms of all of our ABF classifications. So at the moment we're going through some planning internally and with the Australian Institute of Health and Welfare about what metadata might be relevant to go into our data sets. Once we sort of have a little bit of an idea on that, that's when we sort of reach out to the jurisdictions to get their feedback on whether these changes are what are being reflected within the type of care that's being provided in that setting, and any other additional sort of comments or feedback that they may have. In terms of the non-admitted costing study, you know, COVID-19 has been having a huge impact, you know, across the nation on all the services, but that's been put on hold for now. But what IHPA has been doing is we're trying to have a look at, are there other ways that we can gather that information to be able to determine cost differences in the non-admitted space? That's something we're working on. Perhaps we could use the electronic medical record or other ways to sort of extract data on this information to be able to utilize that, making for improvements to that classification.
Okay, so next question. How is an increase in hospital procedure costs due to innovation technology, an example given is capital equipment like a surgical robot, which may be confined to metro teaching hospitals, taken into account in ABF? Noting that capital would be out of scope for ABF, but obviously the question is still applicable. Some activity that might be technology driven and higher cost might be in particular hospitals.
Yeah, thanks, Trent. So each year receives the National Hospital Cost Data Collection, and once we have linked that to activity data, we do try, you know, we identify if there's particular DA which have had increases in costs to, and we, you know, we liaise with jurisdictions to understand if there's specific reasons behind that, which may be related to technology or services being provided at particular facilities. National efficient price determination includes a number of adjustments, and one of those is related to patients' residence. So if patients are travelling from a rural area, hospital, there can be an adjustment to address the additional costs associated with the length of stay, which might be longer than receiving treatment closer to home.
Thanks. So just I mean, just a straight up question, is there still a shortage of qualified coders?
Look, I think the coding workforce, sorry, Trent. Yeah, I think the coding workforce, like many workforces, could always do with professionals. In saying that, the coders that we do have are, you know, extremely knowledgeable and have to go through extensive education to be able to code at public hospitals. So I think, you know, in short, yes, but the staff that we have and the coders that we have out there are extremely knowledgeable and do what they do well.
So, so in your opinion, what is the potential of using survey data such as the ABS National Health Survey or patient experiences in Australia data alongside activity data to support policy or funding decisions?
Well, I suppose we do an awful lot of that, Trent. I don't know about funding decisions, but certainly supporting policy decisions. We use a lot of different survey information alongside all the activity information that we can get our hands on to do things like the Australian Health Performance Framework reporting and other lots of other different performance frameworks, mental health, and drug and alcohol, all sorts of survey information. I think this raises a really important kind of dimension to the conversation when we talk about these collections. And so going back to the questions about time delays in, from receipt to publishing, this is an issue that we face a lot. But you look at the multiple purposes for which these data get used, and one of them is really importantly that long-term trend. And that's often where the survey data is really powerful to keep track of over the long term how things are tracking. And then you can work underneath that with the more up-to-date data to kind of develop policy and costing frameworks. So that's for me how the two things often relate. Although of course, what might be in that particular person's head is the idea of patient experience surveys and things like that too. And they're obviously a really relevant and important tool that's probably underutilized at the moment.
So with the growing focus on ambulatory care, it is very difficult to navigate the different definitions applied by jurisdictions and even harder to understand and compare public and private sectors. Any ideas on how to address this?
It's a really good question. I think in terms of the definitions, I would just encourage to go onto Meteor in terms of having a look at our metadata on there that definitions for different areas of the non-admitted space or the ambulatory space that might be able to sort of, assist with that consistency application across different hospitals or across the nation.
So next question, when is the likely introduction of ICD-11 within Australia at the hospital level?
I wouldn't be able to sort of say the exact time frame for that, but I'd encourage you to sort of, reach out to me to get that. But it's certainly something that is that version. So, please make contact and we can discuss further.
Okay, so next question. Has anyone mapped the journey of patient information from a hospital ward through coding, patient costing, state coding, then to IHPA and HRT to see how accurate and relevant the final numbers are? There appear to be a number of black boxes along the way which move things around, so there isn't a clear connection between what we think is happening on the ground and what national reporting is saying.
Go at that, and then I'm going to ask Kieron to follow up. I think this is talking about the patient's journey and sources or the intervention which they're being assigned as part of their hospital interaction, as well as the costing data. We certainly do look at the feeder systems, the number of pathology records at hospitals, and try and understand how they're being allocated to patients. We look at theatre hours and theatre minutes, and we undertake a review of all of those different systems, and see how that activity has been allocated to patients. That's part of the independent financial review. And we do know that some of the activity isn't assigned to patients. We work with jurisdictions to understand why that is, and I think that the independent financial review does a really good job of understanding the processes which have been undertaken when costs have been allocated to to patients to ensure that there is correct resource allocation.
There are processes in place to make sure that what is being collected does reflect what happens on the ground, including reviewing of coding practices, reviewing of districts and networks in our particular cases, of what they're collecting, and does that reflect what's going on. There are review of medical records to make sure that things are being recorded in the way that we think they should be in the systems. And of course, once they get up to our level, we are looking and reviewing the quality and what is being sent to ensure that it does reflect what we're going through. There may be some variations, and that might be brought out because of different rules around counting or different rules around understanding how that information relates to the process. But in general, we do actually go through and check that the information does make sense and that it is reflecting what's going on. I think, and this goes back to the Meteor, a lot of the time it's really good to read the Meteor and work out, and the IHPA environment, to work out where there may be variation. For example, a lot of non-admitted patients use a concept called OOS, Occasions of Service, which is rolled up to a service event. It doesn't mean the information is any less important, but it does mean the numbers do look different. But it is reporting what is happening.
Yeah. So panelists have worked on national committees to define and establish new data collections. How are decisions made around the establishment of new collections with regard to their benefits and any burden associated with the additional collection of data?
I might jump in. It is a very robust discussion amongst the stakeholders. Gloves off, no holds barred kind of discussion, where we do actually consider the whole process, what it is to incorporate it, the benefit of what that item is going to provide, or those items are going to provide to health, to the health of the nation of Australia and New South Wales in my case, and working through the nuances to make sure that we're not going to bring in something that does not reflect what's happening, or does not bring in something that is usable and answers the question that the collection was set up to answer. And I know that sounds unusual. I've worked in health for a long period of time, and a number of times people come up with this collection will solve all of our needs. But when you go through it with a fine-tooth comb, as we do, you find out that the data that they're collecting won't necessarily answer that particular question. So it is, again, I'll go to Aaron, it is a very robust process.
I think indicative of that is that, and what people probably don't see, is the number of things that don't get through. There's things that have been bouncing around for a decade or more that, and some of them were, identified by health ministers as priority at that very senior level. We need to measure on something like the waiting times to see a specialist to go on the elective surgery waiting list, and we're only just now starting to get some data on that, and that's a decade more in progress through those conversations. So it ain't easy, and you've got to be patient and really consider all the issues that Kieron sort of raised as well.
I think it's also, there are a lot of issues coming up, and unfortunately some issues need to be prioritized, and some issues need to be prioritized on funding and capability of the systems as they exist. There are a lot of collections that I could think of that I would love, because I think it gives a lot more information, but the systems aren't necessarily in place to allow us to collect that. And it's one of those chicken and egg. Do you define the collection and then make everyone build a system to collect it? Or do you have a system that's capable and then define a collection to collect that information?
Yeah, so we've got a seriously upvoted question that says we're getting a stilted, stuttering feed from Julia. So just a heads up to Julia. Like, I think the upvoting means that it's common. So let me just go to the next question. What type of additional data would IHPA require to get more into value-based care funding options? That doesn't mean you're not allowed to answer, Julia.
I think that there is a lot being done in this space. That the IHI, the individual health identifier, would be crucial. Would be highly valuable in improving value-based care options looking at those.
I have to say, I think, oh, sorry.
That's okay, Kieron. I was just going to add to that to just say that we are proposing to collect the IHI on a best endeavours basis, and we're going to be working with the jurisdictions to help sort of assist with any barriers that might come up to that IHI.
I was going to say, for value-based care, I'm looking at the concept of outcomes for clients as well being included in that. And if we look at the Australian mental health, I can't even remember what it's called now, mental health case classification, care classification, that is trying to bring that in. So bringing out the outcomes of mental health clients into the process that is used to help the funding process. So that is trying to bring that value back into the process, what is happening to the client. I may have misunderstood the direction of the question, but to me, the bringing of more of those individualized survey responses allows us to bring more value to the system, because we can actually then concentrate on providing those services that are having a direct positive effect on clients.
Okay, so next question. Are there any plans to improve the capacity to capture data related to people experiencing homelessness? People experiencing homelessness in all forms utilise acute healthcare services at a significantly higher rate than the general population, yet it remains very difficult to quantify. Are there plans to capture this data more specifically moving forward?
I can take that a little bit on board in terms of, we have an area at the Institute who has responsibility for monitoring housing and homelessness, and is quite keen on this and has a bit of a project underway, I understand, to try and link up some of the housing and homelessness data to the hospital's data to get a better, to quantify that issue in a bit more detail. These are tricky things to govern through, of course, with some of these collections and the ethics arrangements and things like that. But it's a really good question and a really big issue. For those of you who know about the story of $1 Million Maury, I'll leave that with you to look up, but it is a big issue.
Okay, so I've got a question on data governance and the role that various stakeholders play. So it's it goes. I understand the importance of jurisdictions in relation to data governance. So they're main stakeholders in that process of establishing data governance, and hence the necessity of consulting with them. But how do other stakeholders get consulted with, such as private hospitals, given these other stakeholders play crucial role in the collection of so much of this data?
That might be, I don't know, a bit broader than, probably is related to the costing work, but in the broader context, certainly the Private Hospital Association, the private health insurers are all very much a part of what is our National Hospitals Information Advisory Committee. So that's one avenue through which they get directly consulted on what we're doing with hospitals reporting and the data work generally.
So acknowledging the justified pride in data sharing between hospital services and jurisdictions, plus important developments such as linking aged care interface, preventable hospitalisations, etc., how optimistic is the panel that there is a real appreciation for the need for improved links with primary care, GP and beyond, at a national level, and what could help to garner that shared and enduring commitment of resources?
Nobody else wants to go. I'll go again, I suppose.
Yeah, I was going to say I'll start naming names if you don't.
Oh, look, it's an entrenched structural issue. A lot of that issue comes down to the division of responsibility in our federation between different funding programs. But one thing I've observed over the last couple of years in the COVID context, for the first time, as far as I'm aware, in Australia's history, we now actually have people getting together on a regular basis at a very senior level who have responsibility across the health system for all its different dimensions and talking about how to make it work better and how to improve it. I don't think it's ever happened before. As horrifying as that is, but sure, health ministers get together every now and again and talk about some big picture issues, but at a kind of more bureaucracy level, there hasn't been that type of conversation before about putting the different bits of the picture together to try and understand how things can be managed better. And that gives me some heart that we might, because I think that's ultimately what it takes. You can, build whatever data systems required or funding mechanisms you like, but if you don't have that type of collaborative, everyone around the table conversation happening, it goes nowhere. And we haven't had it up until now. Hopefully it'll survive, post-COVID and become an enduring part of the Australian system for the long term, because I think that's the solution.
Okay, so Victoria seems to be the only state that invests in coding audits that provide a robust estimate of the accuracy of the data. Does IHPA have a position about what they would like other states to do?
I don't think we have a position per se, but I think you're right that coding auditing is extremely important to ensure that the accuracy of the application of the codes to meet the requirements for the classifications is essential. So, I won't speak on behalf of other jurisdictions, but in terms of, quality improvement, in terms of coding, auditing is a really to ensure that this is being done properly. Another way is, of course, education. So ensuring that our coders are educated on changes and when to apply a code if there is a difficult situation in terms of a challenging admission that might be complex, having conversations around that, submitting questions to IHPA if they need clarification around how or when to allocate a code. Those things combined will assist with the coding explanation.
And of course, like as Julia mentioned earlier on, there are the IFRs that are undertaken with regard to our cost data collection. So there's auditing processes around the actual allocation of costs to the activity level. But what we're talking about here, I think the questioner is talking about the actual underlying activity data collections. So outcomes data often requires some effort over and above transactional data. We have some bodies like AROC or AROC, etc., for rehab and other institutions. Is there an overarching governance or central role for data collection here?
Look, I think, mentioning AROC in the sub case, I think this is really where our governance structure is really important at IHPA. In our working groups and committees, we do have stakeholders such as AROC and others that, come to these meetings and assist with various different issues, including, classification development. We also consult with these stakeholders around changes in metadata and data collections. So this is really where we sort of lean on our stakeholders to get that feedback to sort of progress forward with our actions and our metadata standards.
So a question says, it's fantastic to hear you describing earlier on the data moving towards real-time understanding of the complexity impact of one part of the system with another. How will clinicians who are tasked with the rapid response and model of care, design, delivery, etc., able to get visibility of this data, of this information? I know some states have progressed this, but in places such as Victoria, individual clinicians are very siloed from being able to see the evolution of data presentation, which in turn impedes the ability to engage or think with a system lens.
Well, this is very front of mind for us at the moment in terms of the next phase of work we want to do with that Florence system that I mentioned. We're talking to Victoria, in fact, and other jurisdictions about how we might be able to provide, possibly as a first step, a non-public version of that local area perspective across the different funding programs to health services, to LHDs, to PHNs, so that they can do exactly that. I don't want to raise expectations too high in terms of, it will still be transactional aggregate level data, but it should be a big step forward from what people are able to see now. Well, we can't see anything, so must be some step forward.
So a question for Julia: how can researchers get access to the National Hospital Cost Data Collection?
They can go to IHPA.gov.au. There are processes for applying and having access to IHPA's data. We work with jurisdictions to facilitate that. And we have an analytics space where and other third parties can access that data, so it remains secure. But please contact IHPA using our website to make those inquiries. Very keen for that to happen.
Okay, so a question for each of our panelists. Based on your experience, what would you change to improve our national health data collections? You just get one thing, though, one each. Adrian.
I
Oh,
No,
you
you go.
You go.
I think keep the focus of any of the data collections on, is it making the health of the individual and better? That collection and minimise the burden on hospital staff and jurisdiction.
I'm going to go back to that notion of if we can maintain a body of people who have the job from across the jurisdictions of actually looking at the data on a weekly basis and keeping track of what's happening and how different policies are being implemented and the impact they're having, and using the data in that way, alongside the provision of data back to health services at a local level to be able to use it. Ultimately, that's what will drive improvements in the collections and relevance.
Kieron?
Look, I'll get in trouble for this, but I would love to, and this is following my technical background, I'd love to see a consistent collection system. One of the things within my own jurisdiction is that many different systems and collection of information causes us some issue. But it has to be expanded when you're collecting from other jurisdictions and other ways of doing things. So bringing that information to a standard model takes a lot of effort and a lot of work. A singular, for want of a better word, collection environment might make things easier for us all.
And finally, Laura?
Mine would have to be that data linkage so that we're able to have a look at the patient journey across different settings.
Excellent. Well, that's all we have time for today. Thank you for joining us this afternoon, and to our panelists for sharing their knowledge and experience in this important area. I hope you found the session useful. Please stay online for a moment as a short survey will appear on your screen, and we would appreciate your feedback on the session. I hope you'll be able to join us for the last two sessions in the Q&A webinar series. In April, we'll take an insightful look at the pricing of public hospital services and IHPA's National Efficient Price Determination. And for the final session in July, we'll delve into policy development relating to innovative funding models. You can find out more on our website, ihpa.gov.au/events. We look forward to seeing you all at our next IHPA event. See you soon.